Okay, maybe I would start. So I am a consultant rheumatologist, and I lead the National Service for Hypermobility for the Hypermobility Clinic. The Hypermobility Service has actually been established by Professor Rodney Grahame, who some of you might know. He is the father of hypermobility in the rheumatology. So we are very lucky that it's quite a mature service with lots of networks, because it's been established around 27 years ago. Our funding, and I'll bring that to the discussion, because Roberto, you've got national funding, which we said, I would imagine this is like a special commissioning. Our funding is not specialist, it's actually from our local hospital and from our local commissioners, which makes it difficult, because at times we get always challenged about the amount of time we are spending with our patients. So it's always nice to come here, because people talk about spending 2.5 hours per patient, 1.5 hours per patient, an hour, and I have to fight on a regular basis to get 40 minutes per patient. And I'll take you through how we do it in the UK. But I think, as I said, we're very lucky that this service is mature. It's been for 27 years. I personally have been involved for 15. So in the UK, we've got only two centres. One is at University College Hospital, and the other one at the Royal National Orthopaedic Hospital with my colleague, Dr. Helen Cohen. In our centre, what we do is it is actually diagnostic and management. So we are very lucky that we have access to a number of extremely specialized services that are interested in people with hypermobility-related disorders. So we could talk about Ehlers-Danlos syndrome, we could talk hypermobility spectrum disorder, people with Marfan syndrome, people with Weitz-Dietz syndrome. So we've got this, what we call a connective tissue disorder flavor. So no matter what you have, if it is something to do with hypermobility, we will be able to do it and assess it. Difficulty is about access. So the difficulty is, as you've alluded to, is when it is more pediatric population, maybe the numbers are manageable, but could you imagine our service is 18 plus, so the numbers are quite difficult to manage if it's only a couple of centers. So the way it comes that people can be referred to us, if someone has a definite genetic mutation, we are there for them no matter where they live. And I've had to fight really hard with managers to say, if someone has a genetic mutation, no matter where they live, they come to us, at least for an assessment and a management plan, and then we could discharge them, or not discharge them, we will continue to follow them, but we could do this shared care with their local services. The difficulty is people, if they don't have, like if it's hypermobile EDS or hypermobility spectrum disorder, because of the numbers, we are only able to see them in our catchment area, which again has been stretched over the time, but that's where we are now. When people come to us, what we do is so the referral letters, again, more of practical, referral letters come to us, we triage it. If it's appropriate for our services, we put them through. If it's more of the complex, genetically defined with complex multisystemic, they come to the doctors, because we also have a very experienced physiotherapist. It's called extended scope practitioners. They are physiotherapist consultants who are expert in musculoskeletal, and they could do the assessment, so we could do it together. So when they come to the clinic, 40 minutes, but we have developed this SPIDER questionnaire, as I don't know if you are aware of this, and also we've got the support from the EDS Society, where it's a questionnaire that given to patients prior to the appointment, where you look at multisystemic to assess the multisystemic manifestation, if you want to think about it. When we developed that questionnaire, we initially wanted it to be an outcome measure, but now what we use it for our assessment and also for triaging. So people come in, they would have already built in, like we can come with a radar, we know where to need to priorities. We do a thorough, also medical history examination, and then following the treatment, following the assessment, everyone is invited to come to an educational session. Everyone. So that is about management of what is hypermobility, how do you manage dislocation and subluxations, and also we have been able to send people, we've got a library of physiotherapy exercises that it's relevant for people with hypermobility. So that's what happens in the clinic, but we also, based on that spider, and people where they have when the symptoms have a high impact, we have the option of referring to neurogastroenterology in our center, neurogastroenterology, autonomic center, urology, pain clinic. A pain clinic is an essential part of our service. We work together in that, and we offer people either face-to-face pain management course, or it could be virtual for people who are traveling from a distance. And the pain management is normally over 8 days, and in 8 days they come, there are 2 days for family and friends. We also have managed to, recruit other people, like the menopause clinic, and we have weight management clinic, but all of that wouldn't be possible without actually doing this assessment. People, if they need inpatient rehabilitation, we can do that. It's a course where people admitted for 3 weeks, Monday to Friday, and they go home weekend. I just wanted to say, because of the funding issues, we're always under threat, where managers say, oh, we don't want to do this, we want to do that. And I'm very grateful to EDS UK, hypermobility, like the patient support groups in the UK and EDS Society. When we have been under real threat, they came and supported us with this, and hopefully will continue to do it. I also continue with work with the patient organizations in the UK to try and stabilize these services and work on what we call now national network, where we get a group of rheumatologists across the whole of the UK, and I'm very pleased to lead on that with the Society of Rheumatology, so we could establish services for management and diagnosis, like the assessment and diagnosis across the whole of the UK. I just wanted to say that I have successfully negotiated that hypermobility has to be an established and well part of the curriculum for all the rheumatologists, so all the trainees, they have to go through these trainings. We have webinars on the BSR. This is a big achievement, that the British Society of Rheumatology, there is actually a webinar about sort of EDS and other heritable connective tissue disorders. And as I said, I lead this network for the specialists. So I hope, so currently we're restricted, but with what I've discussed, I think we should be the future should be brighter. Thank you.